Gergo Jozsa, and his presentation is about absorbable endomedular nailing in forearm fractures. Yes.
Okay, thank you so much. I would like to share my presentation. So can you help me to make a host for that?
Yeah, you can share it right now, I think. Please check.
All right.
Great, it's going.
I hope that you see my first slide.
Now it's okay. Yes.
It's okay. Okay, thank you so much. So hello, everybody. Good afternoon, and thank you for the opportunity to present and speak about this, I think, is important topic. So the first description of the technique was described about from Finland, Sinikumpu and his team, and they described this is a new mini-invasive technique with a bioresorbable, elastic, stable intramedullary nailing. It was more than 10 years ago, exactly 2013. So it's not really fresh and not really new technique, but it didn't spread worldwide directly, and we didn't know what is the main issue of that. The operative technique is really similar when we are using to this stable elastic nailing, which is really perfectly described Pierre Lascombe and many others as well. So the insertion points from the radius is the same, and the ulna is also. But the base of the technique, I would like to show that this video, which was made by a friend who is working in Budapest, Marcel Varga. And now you will see that this is the first degree open fracture of the both bones in a forearm. And of course, the preoperative planning is really necessary to measure to the intramedullary canal. After that, you can see step by step. So the small incision to the distal radius. Now it's canal. Also, we use the awl, so that we have the same instruments, the titanium nailing. At the beginning, we need to dilate the medullary canal. We use this steel dilator, and sometimes we need a little curve of that because we want to protect to the opposite cortical layer. Now you can see that how we can find a hole and insert to the intramedullary canal. It's absolutely the same step of the titanium nailing. Sometimes it's difficult to pass through to the fracture gap. And now you can see that under the fluoroscopy, how it looks like. It's a little different because the steel dilator is much more stronger than the titanium nail, so you can make another fracture of the bone. Now you can see how it looks like, and now this is the dilation of the medullary canal. So it's a really important step to make a hole inside of the medullary canal. One dilator is in the place, as you can see that on the fluoroscopy, and now this is the normal way what we can use and how we stabilize to the ulna. I think is really important. You need to fix both bone at the same time. So never try to do that. First, you put the dilator into the radius. After that, remove the dilator and put the resorbable IM nail. So as you can see that again, the dilation of the medullary canal, it looks like not really gentle, but is really important. You will see that later on this video. Now it looks like it's enough stable, the steel dilator in place in both bones. So it's traditional like the titanium nailing. And now again, we are trying to use the dilator. And now you will see that how it looks like the resorbable intramedullary nailing. It's containing the PLGA, polylactocoglycol acid. When we remove the dilator from the radius, we need to find again the hole and the correct medullary canal. And now the gentle movements go forward. We can insert this implant. The end of this implant, it has a tricalcium phosphate, which is fluorescence agent. So you can see that under the fluoroscopy. Now you can see that how we can insert into the ulna as well, so it's not really hard. And the red circle shows that the tricalcium phosphate sign, so that is a good position of the implant. And now how we can cut it, we can use the cauter as well, but also you can use any type of cutter, but it's much more elegant, this kind of instrument. And we usually push it until to the cortical layer to protect any soft tissue irritation of this implant. Of course, everybody has a good case and a good video, so I would like to show another case. This is a 30-year-old boy who had a diaphyseal forearm fracture. I think everybody agree with the indication of the operation, and now how it looks like the postoperatively. It's a good position of the IM nails. This is the tip of the IM nail and the other one. And now it looks like 1 day after the surgery, no any painful for the finger movements, and extension and flexion of the elbow is not painful, but we didn't force any rotation because it's not enough stable. Of course, after that, the operation, we put the cast 1 to 4 weeks, long arm cast. So it's necessary after that, this operation. Why is it important that you know that is a relative stability? You can see on the left side, this is a refracture after the conservative treatment, and recurrent fracture you can see on the X-ray. And we perform the close reduction and resolvable intramedullary nailing, as you can see that, and we use for after that the operation long arm cast. 1 week after that, we put the circulated cast, and after that, the second week, we can shorten it for another 2 weeks. That is the suggestion for us. Sometimes we are using just only 1 week, the long arm cast, and 3 weeks for orthesis. And now you can see that the really good callus formation on the last pictures on the right side. So it's meaning this is a relative stability. As you can see that 6 months after that, the patient's healed, and by the fluoroscopy and X-ray, it shows that it's absolutely healed. And this is a good functional result. And the patients say hello for the doctors. We published several things about this technique and comparison of the titanium nail. And of course, only one advantage for this technique, that is a metal removal unnecessary. And we described to the preliminary experience of these cases. And we have some more than 25 patients who more than 1 year follow-up. So at the time we operated 95 patients. Of course, if I'm talking about that this is a good and new technique, it's not really new, but I think is a good technique. But I think most of them are interesting of the complications and the difficulties of the technique. I published this paper this year, and I would like to show that some difficulties and complications as well. So if you have any experience of this technique, you will see that on the left side, the picture shows that the tricalcium phosphate blocked in the middle of the diaphyseal part of the radius. And if we can see the magnifying picture, you can see the sunglass effect. Unfortunately, the dilation and prepare of the medullary canal was not enough. So that was the reason why the intramedullary nailing blocked in the level of this radius. So sometimes we see that, but it's probably healed this patient. And really difficult, the distal third of the diaphyseal forearm fractures. When you insert the dilator or the titanium nail, usually you see that the difficulties of the opposite cortical layer, and sometimes you make another broken, and after that you will be at trouble how you can fix this fracture as well. So at the time I started to the steel dilator, as you can see that like this direction, and I cause another fracture, so longitudinal fracture of the radius somewhere here, and as you can see that the red line, and I inserted to the banded elastic nailing, and I solved this problem. Of course, the preoperative planning is really important, And if you measure to the medullary canal less than 2.5 millimeter, you won't be able to insert the smallest 2.7 millimeter resorbable implant. So you make a change your mind. At the time we put the 2.0 millimeter titanium nail to the radius and 2.5 millimeter to the ulna. And that was the reason why I can't use the resorbable implant. So let's move on to the complications, because I mentioned for that some difficulties you can manage to the intraoperatively. I was the operator on that case. This is a 10-year-old boy. This is a proximal third of the diaphyseal forearm fracture. And I made a close reduction, was a good alignment. And during that, the insertion of the IM nail, I felt something the problem, and I used the hammer. And I was lucky because the tricalcium phosphate goes out of the bone, and I see under the fluoroscopy on the membrane, interosseal membrane. And I remove the IM nail, and you can see that it was splitted. And the reason was that when I reach to the fracture gap, unfortunately, the tip of the nail, it was blocked to the fracture line. And when I used the hammer, it's much more force, that was caused the splitting of the IM nail. As you can see that on the postoperative X-ray, so the radius reduction was not anatomically. So I removed this implant at the time of the first operation, and I insert another one, and you can see that after that the post-op X-ray showed that is a good position. And of course, if we are talking about the post-operative care and follow-up is important, as you can see that again the middle third diaphyseal forearm fracture, the post-operative X-ray, not the best, but I think is acceptable. You can see that not the perfect reduction of the radius. And 1 week later on, the control X-ray showed that the radial angulation, and 8 weeks after that, there is a good callus formation, and the functional result was almost perfect. Of course, this patient is ongoing on the follow-up. Always question when I speak about in the EPOS or any kind of trauma sessions, what can we do if we have a refracture? So now that this case, 6 weeks after the operation, the patient went to the trampoline again, but we didn't suggest for that, of course. So you can see that the AB shows that the 4 week after to the operation, the control X-ray shows that the good alignment and good callus formation. And 2 weeks more, when the accident occur again, you can see that the smart angulation of the radius and the fracture line much more sharply than previously. So we put the cast without any manipulation, and the conservative treatment after 6 weeks, the 6 months, you can see that completely healed this fracture. So if we have a recurrent fracture, because this IM nail was inserted 2 years before then the recurrent trauma occurred. So you can see that 2 years after that, the IM nail insertion, you can see that the growing potential during the 2 years, because that was the end of the IM nail. Here we have the radius, that was somewhere here, the insertion point. And now after that, we decided to the close reduction, and we put the 3.0 millimeter titanium nail. And it was really easy to insert. There was nothing inside of the medullary canal. It was close reduction and close management, and the operation was 15 minutes. So again, I would like to say thank you for my friend, Francesco. So a really good time for in Barcelona with you, and also I think your memory to Hungary together operation. And of course, thank you for your invitation. Thank you.
Thank you. Some question?
Yes, we have some questions in the chat. Do you want to read it, Shane? Or Gergo directly?
I see the questions. I'm trying to, yeah.
Great.
price of one resolvable nail compared to 10 or key wire that is coming from Česko? Yeah, it's also a really good question. So we compared, and I can say about that in Hungary, 10 times more. The price is 10 times more than the titanium nail. So it's really expensive. If you use the key wire, of course, that is the cheapest part. Or if you have a case that just only the green streak fracture, you put the cast and you can manage by the conservative way, probably that is the cheapest. In Hungary, we follow to the PLS-COM management. So if we have a green streak fracture is more than 20, 30 degree angulation, we are going to the theater and make a reduction and put something inside to the medullary canal. So we are a little bit invasive, not so really agree with in everywhere in the Europe. I know that, but yeah, it's expensive. So if we are talking about the price, yeah, it's really expensive. But if we can see that the second operation time around 1 hour to rent a OR, it's probably the equally in Hungary. I don't know in worldwide how it looks like. But if I want to rent a OR for 1 hour to the metal removal, finally, the price will be the same if we are using to the resolvable implant. Is it good for you, Česko? Okay.
Good enough.
Good enough. How fragile is it? Can you break it while inserting? Yeah. As I showed at the video, that was an easy case and it was done perfectly. So if you put a long part of the IM nail and is so far from the insertion point and there is an inserter, it make a bending. It won't be broken, just make a bending, and after that the insertion will be difficult. So you can't make a broken because it's really elastic. So you can break it during the insertion. But now we can see that I had a case when I operate the patient, the forearm fracture. After that, the 2.7 millimeter IM nail I used. After that, under the fluoroscopy, it looks like the Harry Potter hand, so it was not enough stable. I put the cast, that is really important. And 1 week later, unfortunately, this patient had an appendicitis. And we went to the OR to perform the laparoscopic appendectomy. And I checked the stability of the forearm fracture, and it was absolutely different. It was enough stable, and I can't see any movement of the forearm. So at the beginning is not enough stable. That is the reason why we need to put the long arm cast. The time is a question, 1 week or 4 weeks. It's not so really clear. We suggest, and the company suggests for 4 weeks long arm cast to use after that the IM nailing. Yeah, and also coming from Česko, this question, after removing the dilator, do not lose the reduction. If you have an assistant and you hold the arm and the elbow like the straight, you want loss of the reduction. Sometimes we have a difficult case, and I put the percutaneous key wire to hold the good reduction position, and during that the manipulation, I killed my key wire. So it's in the technical tips. If there is a difficult reduction, I mean, you are doing so many elastic nailing. The titanium nail is enough strong. When you pass through to the fracture gap, you make a correct reduction. If you remove the dilator and you lost the reduction, you put again to the dilator and you can try to reach and hold the good position of the forearm. That is really important, the stretching the arm during the operation. So the assistant hold one hand to the hand and the other one is elbow. So that was the answer for this question. Also coming from Česko, I do not remove endomedular nailing. Would it still make sense using these nails? Yeah, it's a question different in any part of Europe and worldwide. who removed the titanium nail from a forearm fracture. If you are not removing these implants, of course, there is no any advantages of the resolvable implant. Yes, I got the answer so many times from EPOS, but I read the publication about the wrong effect of the titanium concentration of the blood, and is well published from the orthopedic surgeon who do a manispinal reconstruction, and the titanium level can cause the azoospermia and premature born and so on, and later on. So it's published. So the titanium concentration of the blood can cause several effects the later of the age. And it also was the first prize of this presentation, I think 4 years ago in the EPOS. Yeah, we compared, this question about to the compared surgical time to the classic metal technique. When I mentioned my slide to the comparison of the titanium nailing and the resolvable IM nailing, at the beginning was 2 times more to the operation time. After that, the learning curve, now it looks like the similar time of the operation. But I think the radiation time is a little bit different, because when we are doing the dilation with the dilator, we are removing, we need to check to the axis and the alignment of the bones. So we are using a little bit more seconds of the radiation, but the operation time is not really prolonged than the metal time. So around just 20 minutes, 30 minutes in easy cases. If you have a problem for the reduction, I'm usually start with the titanium nail, and if it's a problem during the insertion, I stop the operation and I change my mind and I don't want to insert to the resolvable implant. Yeah, it's again the cost about the question. I hope that I give you a answer. From Scott, the question, how strong compared to other implants? We have some experimental studies about the screws and the pins, but we have no any experimental studies of the IM nails versus titanium nail. If you hold your finger, the resolvable IM nail, you won't believe for that is enough strong to hold the fracture. After that 1 week of the medullary canal and effect to the blood and the red cells, it's make a form, and the resolvable IM nail became much more stronger. I see that when I use several times insertion inside of the medullary canal, and the third time I inserted, of course, is the one patient, I inserted the third time is much more stronger than the beginning. So you need to see that the first patient, after that the insertion is not enough strong, put the cast. 1 week, 2 weeks later, you make a force to the rotation of the controlled patient, and you will believe this technique. Because I didn't believe for that is enough strong to hold the fracture, and depend on the age, depend on the size of the child, depend on the muscles. So in my practice, the indication is between the 6 to 11 years old child is not so strong and not so big muscles around the to the forearm. Okay, Scott, what do you think about that? It's accept to you, or do you have any more questions about this topic?
I do not have any more questions. Thank you very much.
Thank you. And from Carlos, any immobilization after IM nail fixation? I think I try to answer it. So it's necessary for a long arm cast 1 to 4 weeks. how long it months it's become resolved? Andreas' question. The tricalcium phosphate still remain after 3 or 4 years after that the operation because it's built up to the bone. And the PLGA resolved 2 years after. And we performed the MRI. What I showed that the recurrent fracture after that the 2 years of the insertion of the IM nail, we performed the MRI and we didn't see any inside of the medullary canal. So it looks like absolutely resolved. And it was the same experience of mine during that the insertion of the titanium nail, because there was no any block insertion of the titanium nail. Also, it's a good question. Any foreign body reaction?
Can I add something more about that question? I write it down. That okay, about the how long it makes resorbable. So the question, it's still in the bone after 3 years, as you said, but in a 2 years refracture, you didn't have any problem to put another endomedular nail. But so the question is not that. So the question is how long it becomes fragile, or it's not more a rigid fixation because of the resorption. So because Lascombe and Metesol says that you have to reach the metallic endomedular nails at least 6 or 12 months in order not to have a refracture. So how long it becomes resorbed for the stability?
I understand your question. Yeah, it's absolutely true that around the maximum it starts from 1 week or 2 weeks to the it's elevated the stability. It's reached to the 2nd week and it's a plateau for 6 to 8 months, and after that it can goes down, but really slowly, not directly. It's really slowly can goes down. That is the potential for a good healing for the forearm diaphyseal fracture. So I think is a suggestion, because when you remove 6 months after that the titanium nail of the diaphyseal forearm fracture, you remove it and directly goes down. It's healed or not, we don't see exactly. On the X-ray we see, okay, it's a good alignment, good callus, and good everything go bone healing, but we can see what can cause during that the removal. And that is the reason why some colleagues suggest to 1 year to the removal. Yeah, Matazio and Pierre Lascombe suggest after than 6 months. Yeah, it's absolutely, that is true. Okay, the foreign body reaction, we haven't seen any reaction because it's absolutely how can I say it? It's in nature. So every time it's built up in a PLGA in a human body. So there is no any tissue reaction. If we cut the level of the skin, the resorbable implant, we can see any irritation like the titanium nail. We can see any foreign body cyst around the nail. So we can see any irritation. So it's absolutely the normal around the soft tissue. And my favorite question is from Carlos. What about displaced refracture with the nail not resolved yet? Any way to retire it? Yes. So if you have a fracture, what I mentioned for you 6 weeks after that the insertion, you can make a reduction if it's not totally displaced. You can manage by the conservative way. Option 1. Option 2, if there is a complete refracture and the implant still in the medullary canal, so it's a window range 1 month to 6 months, you need to remove the implant. Had no experience for that. One of my colleagues from Swiss, he had the experience for that, and we made an open 3 centimeter to the fracture gap, and they possible to remove to the IM nail. It was 2 months after that the primary accident. So we have just one case when they removed the IM nail and he put the titanium nail after that this accident. So that is a really good question, and we have not so enough experience for these cases. But so the option 1 was the conservative way. Option 2, to make an open and remove to the IM nail. And if it's not possible, you make an open and put the plate. So it's not really good option. But the last, if you have no any chance to remove the resorbable implant, but we have no that time of these cases. I hope that you agree with me that, Carlos, if you not, please write me. And also it's an interesting case that have you used it in other bones like humerus, tibia, femur? No, this is a clear answer. I didn't try to use it. Of the company, they have 3 different diameter of the titanium nail, or the resorbable nail, sorry, 2.0 millimeter, 2.7 millimeter, 3.2 millimeter. I haven't used 2.0 millimeter because it's really thick, and I don't believe any time of that is enough strong. 2.7 millimeter, it's a younger population, it's probably good, but 3.2, what I would like to use in all cases. So I'm trying to do the biggest hole in the intramedullary canal because that is the biggest force to hold the fracture. So we didn't use any kind of long bone fractures. And also the good question from Ifasha Gashim, what is the risk of infection? As the same, I think when you use the titanium or steel or any kind of materials, you will have some case of infection. We have one infection case after that the open fracture, and that was the osteomyelitis, and that's the same like the titanium or any metal. So it was a resorption around to the implant, and I can remove my finger. So, and after that we manage like the mandatory, as you can see that on the in the metals. So it's not any differences. So in Hungary, in the 2 centers operates resorbable IM nail, the forearm fractures, and we operated together around 200. And we have 2 refractures, but those of them was treated by a conservative way. We have 2 refractures, recurrent fractures, so more than 2 years after that the first operation, and 1 infection, which was osteomyelitis, and it's healed by after that the removal. And there was no any other complications, like I showed that the smart angulation after that the operation, it's meaning between 5 to 15 degree angulation postoperatively 1 week or 4 weeks after that the operation. I hope I find all questions. If I'm not, please help me a little bit. If you have any more questions, I am here, so I am open. And I really thank you for that interesting and the many questions.
Thank you. Thank you,
Thank
Joseph.
you.
So next is my presentation. So I introduce some experience about Wassel-type III, some product 3, but is we can see the different all kinds of type 3. Disease different type 3 productly is the same treatment. Is we can see the different the size and deviation and the short and height. So I have some experience. Wassel-type III, some productive after improper surgical technique, we can see some not good outcomes because of joint instability, persistent deviation, non-parallel joint surface, and unsatisfactory aesthetic outcome. And this paper, I would thank you, Dr. Takagi, and he sent me his paper about his experience about Wassel-type II and 3 radioproductive. And in his paper, he also think type 3 maybe some deviation after resection. Post-operative like this type 3 only do resection because of loss of support. At last, we can see there is a deviation and the joint is not stable. And he did a re-operation, and at last he suggested to modified procedure, cartilage preserved and preserve osteochondral stability. And this is Takagi's experience. And this another papers published by Kim, and he's modified the Wassel-type III productively three subtypes, and this is a parallel type and divergent type and convergent type. Every type he also do resection after this the post operation. Also his papers said after this post operation deviation like this type A, I needed to do re-operation, and also he suggested do resections to keep this cartilage. The similar technique with Takagi. So this is another divergent type. Also do after surgeries deviations the MP joint. And this is a convergent type, and after resections, so the IP joint is not stable and deviation. So I will share my 10 years experience about Wassel-type III, more than 100 cases, and how to do these techniques. The optimus function. I would like to optimize functions outcome and enhance aesthetic appearance and minimize complications to do this type 3. And my experience is I classified this as 4 subtypes and 4 surgical techniques. It's different subtypes as in the different surgical techniques. This is type 3A and 3B and 3C and 3D. So I will introduce different subtype. The key assessment is from the osseous morphologic pattern and IP joint stability status. This can see from the MP joint. MP joint head is the B, and this is the A, and this is the C. So the ABC is very important to assessment. It's from radiography. This is ABC. because the A is the size, the A is more width, and the size is more big. So from the aesthetic, so we need to the similar size to a normal sum. So this A is very important, and the C is to assessment the IP joint stability. The interduplication distance. And this is subtype 3A. 3A is the similar proximal phalanges and metacarpal head width. So these A and B are similar. And cheetah is modified BC procedure in Wassel-type II. Only modified BC procedure of the disc phalanx, just the disc phalanx, and these make like type 2. So we needn't to do anything about the proximal phalanx. This is type A. And especially height discrepancy between the duplicating sums. Dominant sum is greater than minor sum. So I exists for advancement of the minor sums distal bone segment. So maybe it's risk of post-operative deviation. I used to do modified BC procedure of the distal phalanx as a composite neurovascular island flap of the minor sum. I like this case. A modified BC procedure of the disc phalanx is a composite neurovascular island flap of the minor sum. This is subtype 3A. S is shorter, means this is a radial side is shorter, and is from X-ray is a different height. This is a modified BC procedure is copied from the Professor Baker his paper published in JBJS. And this is extra-articular procedure and bony coaptation, intervergence joint instability, reconstructed with the dominant sums IP joint, no articular surface approximation. And this is subtype 3B, and 3B is a very wide C and very wide C, and A greater than B, and then joint instability, and its digit is bending, twisting, or deviation. So our technique is modified BC procedure of the distal and both the proximal phalanges, like this X-ray, both proximal and distal phalanx. After these techniques, we can see this the joint is stable. This is so modified, and the radial side, I also do there's a neurovascular island flap, and distal and proximal phalange is the segment, and the A, because A is greater than B, so decreases the proximal phalanges width and enhance IP joint stability, and makes the proximal phalanx is have a similar size with the normal side. And this is subtype 3C. 3C is joint is stable, and the digital is strength, no bending, predominant size of the dominant sum, and this is like you can see that type 4. Type 4 we can do minor sum resection and APB and corrector ligament detachment and neurovascular island skin flap. Type C different to type B is because of this. We can see this is strained and the IP joint is stable. And introduces a subtype 3D. From this different age cases. The first case is adult. Adult we can see is typically is type 3, and this is the second case is 3 years old. 3 years old. We can see the proximal phalanx is almost to type 3, and the last one is only 10 months, 7 months old. So we can see like type 4, but this is type 3. Type 3D. At last, when they grow up, they will grow up like this adult. So the subtype 3D is typical. It's minus some resection. We can do APB and correctly ligament detachment. On the correctly ligament plication of the IP joint and flex the tendon rebalancing, and open wedge corrective osteotomy of the proximal phalanx or neurovascular island skin flap. And this IP joint, like do type 4D. Open wedge, we can see this when we resection to harvest island from the radial side projectly, and to resection this open wedge osteotomy, and then this bone graft harvest from the projectly. This is subtype 3D. So outcomes. Post-operative some deviation and instability correlated with mismatched surgical techniques. Choosing the right surgical technique for each subtype helps improve function, appearance, and reduce the complications. And this is type 3A, we only do distal phalanx BC procedure, and this is the dominant side, and after follow-up, we can see the size and the nail and the function, and is good, and no deviation. If we only do section, the IP joint is not stable. If we only do section and do this to modify the resection, but the only one some this projectly resecondectory, and this is not good aesthetic. Is too small. This sum is too small. So I recommended to do this BC procedure. And this is the type 3B's outcomes. Type 3B's outcomes, I suggest both of proximal and distal phalanx to do BC, and I usually to do design the radial side to flap, radial side flap to do neurovascular flap to keep the distal phalanx and the proximal phalanx. And this is after outcomes to follow up. We can see the distal and flex is bone union, and this is follow up. And IP joint is stable, very stable, and IP joint, no deviation. And this 3C is more easy to do, and just like to do type 4 projectly. We resection radial side and to retachment APB and correctment. So this is type C to the technique. And type 3D. Type 3D, we designed the radial side neurovascular and flap and to the open wedge and to make the radius on the side strange and type 3D. So I would like to introduce this the last cases about this, like similar the middle hand, and I very like BC procedure. So when we see these cases, we can choose the second digit to do polarization, but the second digit is very small and smaller than his index fingers. So is X-ray. So I designed this modifying the BC combined polarization and usually polarization is the second digit, and then I harvest the radial side the productly to make combine these techniques. So we can see the X-rays distal. We just need the distal phalanx to do the BC and tendon and the muscle and the tendon and just like the normal polarization. So thank you. So this is my presentation.
Incredible, Jane. Incredible. Scott, do you mind to guide the discussion of this talk?
Yeah, so, Jane, a couple questions from the chat. Do you use any advanced imaging of the thumbs when deciding your classification, like an MRI or ultrasound? You hear me? Let me repeat, Jane. So, do you use an ultrasound or MRI when deciding the type of thumb, the type of type 3?
No, I tried, but it's not very easy to. I need to anesthesia so to children. So yes, I didn't to adjust the assessment from the X-ray.
Okay. I know that Dr. Wu in Korea is using a fast MRI with just some sugar, and he does it on most of his duplicated thumbs to try and get an assessment of the cartilage. So it's something to think about. Jane, the second question is, obviously what you showed appears to be difficult. Is it difficult to do these operations? Are the surgeries difficult?
It's not very difficult. I do this is more careful, and to make the bone, to like scuttle to. I think too much productory cases to do this. We can learn curve.
Yeah. Yeah. So then this a segue to that question is, there's always been problems with the nail after Bill Hout. Do you have many problems with nail deformity?
Not nail formatted. I use the very small 9-0 proline suture to suture the nail bed, and to use the microsurgical instrument to do this, and to make the bone very plant and the nail. Not only type 3 but also type 2. Type 2 and type 4, type 6, I do a lot of cases use this BC procedure.
So with the 9-0
Scott?
suture, yeah, go ahead.
Oh, nail is good. Not
Paco.
yes.
Scott, regarding your question or your comment, I used to say that I used to recommend not to do below cloquet because I never had a good cosmetic result. But then I saw Jane Shen doing the surgeries, and I use her technique, and now I have better results. So I put that. I think it's difficult, but at least you have to see her to do it, because if you don't see, you can read the technique, but if you don't see someone doing it properly, I think you cannot get these results.
And Paco, do you use an Ino suture also?
I can show.
Yes, I do.
Okay.
I can show a
Yes,
video.
I mimic. I try to mimic her.
I think everybody does. What'd you say, Jane? You have a video?
Yes, I have a video. Yes, I can show my video.
I'd like to see it actually.
But even with Jane, even with the video, it's not enough. It's not enough. I think it's necessary to be in the OR to be with you or any person doing it properly to learn how to do it.
So Paco,
So I
there's
think it's
55 people on the webinar. So if 55 people showed up to Jane's OR tomorrow, that would probably be too many people.
I don't think so.
Yeah.
Should I to share my video? Oh,
I think Paco, I think we have a minute or so. Yeah, yes. The
5
answer is yes.
minutes.
Yeah,
5
let's show
minutes.
it.
Oh, okay. I will to find them.
Of course, Jane, you are the chief today.
No, I'm so curious because it's such a different way that Jane has proposed to treat these type 3 thumb polydactylies. And it's obvious that she has thought way more about this than we have because she has this wealth of experience. I haven't done 100 type 3 thumb polydactylies in 20 years. So it's really an amazing experience. And it just goes to show when you look at a difficult problem in a different way, you can change the treatment paradigm. But Paco, you have changed because of Jane.
And
I think
we are
that's what's
treating.
important.
Of course. I didn't believe in below cloquet. I didn't believe in that technique until I saw her. And I used the technique she's using for 3C for every thumb duplication. Yeah, it's just excision and ligament reconstruction. It's yes.
Is this classification published? Do you know, Paco?
Yes, I will to find this just.
If you can't find it, don't worry about it. But did you publish this technique, this classification, Jane? Paco, do you know?
Yes, I submitted this in as European.
I think if we could ultimately distribute it to the participants, that would be helpful. I don't have the reference, or else I would distribute. Paco's looking for it.
I think she said that the classification was published by Takehiko Takagi.
So Andres, if you can,
not really.
Well, what we can do, if Jane can't find it, we'll move on to my talk. But then if
yes, move on. And at last, I will share my video.
Yeah, and then Andres, if you find that, if you could just stick into the chat.
Okay. At last, I will share. So to move on these PULM talks, yes.
All right, so I will share my screen and go into my talk, I think. Do you guys see my talk?
Yes.
Yes.
You see it a full screen?
Good.
Yes, it's okay.
Okay.
Not full.
Well, let me try this again. Hold on 1 second. Not full or not? Yes, full. No, not full. Let me,
I think
No,
it's full.
no.
let me try one more time. Full or not full? Let me
Yes, I
switch.
think it's okay.
Yes,
Okay.
it's almost full. It's a weird.
Is that full or
Yeah,
no?
I think it's okay.
Okay. So Paco asked me to talk about interposition arthroplasty, and I will talk about interposition arthroplasty, but I want to talk about other challenging pediatric elbow cases that we see both domestic and we see abroad, because there are challenging, difficult elbow cases that we see routinely in our practice in Philadelphia and as we travel around the globe. There are some take-home points about malunions and non-unions in the elbow. They're extremely common in low and middle income countries. They have a tremendous amount of disability on children. And if you can fix them, it has a huge impact on their life from a vocation and avocational standpoint. It leads to pain relief, it leads to improved function, and ultimately it allows these children to work in the employment in the working force. If you remember, in 2016, the Lancet Commission was published on global surgery, and it indicated that about 15% of world's disability is due to surgically treatable conditions, and that injuries alone cause about 6 million deaths yearly, more than the combination of malaria, HIV, and TB. So surgical missions and surgical treatable conditions are necessary for fractures. This is a mission in Guatemala. And when they cast them, the fracture typically migrates into varus and has some type of rotational deformity. The way we fix it, especially on our mission work or outreach mission work, is we keep it simple, stupid. It's a simple principle designed by the United States Navy in 1960. We perform a lateral closing wedge. We may offset the wedge to decrease bump. We don't do many dome osteotomies. I know Paco does a fair amount of dome osteotomies. I think when we're abroad, it's easier to do a lateral closing wedge. We want to offset the wedge. If you offset the lateral wedge, you decrease the lateral prominence, and then you can choose alternative configurations if there's a severe deformity. Here's a technique. This is an 11-year-old girl in Guatemala with a supercondor. And you can see, let me go back a second. Sorry, you can see how much varus she is. She probably has a rotational deformity. We often don't have fluoroscopy. So here's her deformity. Here's our preoperative planning. So note the wedge is offset. So the distal line is not quite parallel to the articular surface, because if it was parallel to the articular surface and you did your closing wedge, you get a very prominent lateral prominence. If that makes any sense. So here we are on the operating room table. I'll do a lateral approach, straightforward. We tend to put in these large diamond pins to gauge our wedge that we're going to remove. We then use a saw. We remove the wedge. As you see, we complete it with osteotomes. You don't want to violate the medial cortex because your entire construct will become unstable. Here's the wedge being removed. And then prior to cracking the wedge, we'll place a few Steinman pins. So these Steinman pins are drilled percutaneously across the osteotomy site. They're withdrawn. The osteotomy is cracked, and then the K-wires are advanced. So here the K-wires are in the osteotomy site. Here we close it and pass our K-wires. And here's the post-operative correction. So fairly straightforward. And we do a lot of these on our outreach efforts. And here she is. I'm not sure she's happy to see me, but I'm clearly happy to see her. Jeff Greenberg is depicted here on the right side of the screen. He modified it. He found in Guatemala we had trouble with it sometimes with the Steinman pins. So we sometimes will now use staples. So it's the same technique, exactly the same technique. But then we'll a staple that we bring with us, and then we remove the K-wires. So an alternative to avoid any Steinman pin or K-wire removal would be these staples. Moving on to lateral condyle fractures, and we see a lot of these in the States. I think it's an undertreated fracture for multiple reasons. Remember, most lateral condyle fractures begin along the lateral corridor and end up in the ulnar trochlear joint, or a Milch type 2, like you see here. So the fracture not only violates the lateral metaphyseal area, it violates the ulnar humeral joint, and these should be overtreated. If it violates the epiphyseal cartilage, it will displace. Plain and simple. So we did a case last week. We were unclear whether the fracture violated the articular cartilage. Took the child to the OR, performed an arthrogram. Arthrogram showed that the articular alignment was maintained and there was no dye that was emanating through the epiphyseal cartilage, and we treated it with just percutaneous pin fixation. So the anatomy, the acute chronic, you need to understand the anatomy, you need to understand the biology. The other biologic problem with these fractures compared to supracondylar fractures, they take much longer to heal. So rather than the typical 3 weeks for supracondylar, these are going to take up to 5 weeks for them to heal. And like I said before, here's the common misperception. These fractures begin lateral, end up in the ulnar trochlea joint. Example from the States, this is a 2-year-old child who fell off a slide at daycare, injured a right elbow, placed in a splint, referred for evaluation. This looks like an innocuous fracture. This is your lateral condyle fracture. It doesn't look too bad, but what you don't see is whether or not it violated the epiphyseal cartilage on the ulnar trochlea joint. That's the point. They put her in a cast and she followed up in 3 weeks, boom, displaced. So what do we know? We know that that initial fracture violated the epiphyseal cartilage and was doomed to shift and displace. We can still manage this at 3 weeks. It's not too difficult, right? What went wrong? She was non-tender. We can't allow it to remodel because it's articular malalignment. We need to operate. It's a fairly large lateral approach because you have to see fairly far medial. If you see somebody with a small incision, it was somebody that didn't understand the anatomy, because you have to see the ulnar trochlea joint. You want to avoid posterior dissection if possible. One question that our fellows always ask is, what about the metaphyseal malalignment? Often the metaphyseal will have some comminution or some interval healing. It won't align perfectly. It doesn't matter. What really matters is that the ulnar trochlea joint is aligned. It doesn't matter whether the metaphyseal component is aligned or not. Make sure you don't have malrotation. Here it is fixed, and there it is healed. This is our standard pin configuration. This has been shown to be the most stable. 1 across the spool or across the distal piece, and then 2 up the column. Once it's established, it's a big problem. You end up with a decreased range of motion, tardive ulnar nerve palsy. I always wondered how bad this ulnar nerve palsy could be. Dan and I recently saw a patient with a lateral condyle malunion that went into marked valgus over time. She had no ulnar nerve function whatsoever. 0, and clinically and on EMG. So it's a real deal that the ulnar nerve cannot take this chronic prolonged stretch over time. This also is more common in developing countries. These are really difficult to treat, and you can make them worse. So it's a big problem. So with most big problems that we have, we need to divide it into smaller problems. Problem number 1 is a malalignment of the elbow. Number 2 is the non-union. And there's a little bit of a quandary. Back in the day, we used to try and fix the non-union first and then correct the malalignment. Now we do it on a single stage where we want to fix both at the same time. So here's an example. This is a 10-year-old who had elbow fracture 4 years ago, treated with ORF, believe it or not, told the fracture was healed, has progressive deformity. Here's his left elbow. You can see the valgus deformity. So if you carefully look at the x-rays, you see a little bit of a fishtail. You see the lateral condyle non-union, and you see the marked valgus. So you can imagine how long that ulnar nerve is traveling around the medial side of the arm. This child, the ulnar nerve was fine. Now here's his range of motion. Here's his extension, not very good. So our current treatment is to fix the non-union and the cubitus varus at the same time. You need to be careful about extensive dissection. So when I say fixation of the non-union, it's typically in situ. You may want to scrape it up a little bit, but you don't want to take down the entire non-union with the arthrosis and an unsalvageable problem. And this is the article that we used 10 years ago that changed our treatment paradigm in 2006, and now we do them at the same time. A fair amount of diagrams, but what you see here is this dome osteotomy, which is easier said than done, and you see the lateral condyle non-union fixed in situ. The technique, this is back to our patient. You can do prone or lateral. You always want to go posterior. We'll talk about technique and rehabilitation. Tourniquet is used. Here's your posterior approach. When the anatomy, lateral fixation and the medial fixation. And note, once the valgus has been corrected, look how loose the ulnar nerve is, because now all the tension has been released as you corrected the valgus malalignment. Here's the postoperative x-rays. So if you note, the elbow is no longer in valgus. The non-union side has been fixed with compression screws, and we have medial and lateral plates for good firm fixation. What really counts is how did he do? Here's his extension, here's his flexion, here's his pseudopronation, and here's his final x-ray. So that is our current treatment for lateral condyle non-unions. But saying that, this is the long-term follow-up I'll show you. He's discharged. When you're traveling around and on outreach missions, sometimes you can't always fix them. These are sometimes too difficult. So in 2019, we saw this kid named Rudy, 8-year-old male. He injured his elbow about a year ago. He was treated in a cast. He complained of right elbow deformity. He did not complain of pain. Here's his Guatemalan x-rays. This is the best we could do. And what you see is this lateral condyle fragment. Now that fragment is obviously much bigger than you can see on x-ray because there's a fairly large cartilaginous component, and 2, much more rotated. So it's spun way out. This is not an easy operation. If you look at the child, here's his lateral prominence, but here's his range of motion, which is full flexion and full extension, as you see here, and he has no pain. So in these particular cases, I think it's a risk benefit. You have to decide whether you can fix that piece adequately without killing it and get AVN and without creating a fishtail. One of my mentors, Howard Steele, used to say, never treat an x-ray. So in this particular case, we did not treat Rudy. We let him be. Now, moving on to the topic that Paco asked me to address is interposition arthroplasty. Nobody does a lot of these. We do not do a lot of those. We probably do a couple of them a year. That's all we really do. But we're going to show 2 particular cases. One is the typical ulnar humeral joint, and one is the radial capitella joint. So this is a line. She's a child that was originally from Congo. She was robbed when the mom was pregnant with Aline. Her parents were shot and killed. She hid under the bed to escape the intruders. And then she ended up in a refugee camp in Malawi. Now, while she was in Malawi, she fractured her left elbow and underwent some type of surgery. They ultimately got to the United States, and they were granted passage, and she resided outside Chicago in the Midwest. She had a stiff and painful left elbow. She couldn't even feed herself. She couldn't reach her mouth. She did have full forearm rotation. All her nerves were working, which is an important preoperative determination. Here's her examination. That's her flexion, and that's her extension. So very minimal range of motion, in addition, painful range of motion, because that little jog of motion is problematic. This is just showing that a radial nerve, median nerve, and ulnar nerve are all working. Here's her x-rays. So let's just spend 1 second here. This is challenging. This is hard to discern where everything is. But here's her distal humerus. Here's this glob of fracture management. You see her ulna, you see the radius. And here is her, on the right side, you see a lateral. That's really hard to decipher what is what. Here's her CAT scan, a couple slices. You can see there's no ulnar humeral joint on the left side of the screen. The ulna is displaced in a medial direction. These are difficult problems to treat, and I recommend you ask for help from a friend. So what's the plan? The plan is interposition arthroplasty. Now that's the plan. Carrying out the plan is what's difficult. We need to take our time, find the nerves, make sure they're out of harm's way, and then proceed with our interposition arthroplasty. I think the door to the elbow is the posterior approach. When in doubt, perform a posterior approach. You can raise flaps and enter medial lateral. It actually took us about a half hour to find the ulnar nerve, right? Because it was squished behind that olecranon that was displaced in the medial direction. But just take your time, find the ulnar nerve. You may have to use electrical stimulation to help locate it, because one thing that's not normal is the anatomy. The anatomy is so distorted, it's hard to figure out where you are at any particular time. Now, once the ulnar nerve is out of harm's way, then you can address the joint itself. So now we're going to expose the distal humerus, which looks nothing like a distal humerus, but that's her distal humerus. Then we're going to have time to make an elbow joint. So you want to make sure that there's adequate room for whatever coronoid and olecranon is left to enter into the olecranon and coronoid fossa. So typically it's some form of outer bridge type of hole, as you see here. And then what you want to recreate a convexity and a concavity, a convexity of the distal humerus and a concavity of the ulna. And just take your time and try your best. But this is a Herculean effort to recreate this joint. Then we're going to perform our interposition arthroplasty. We tend to use something of Achilles graft, as you see here. We make sure there's wings if we want to recreate the collaterals. You don't want to make it just one ply. You want it 2-ply thick so it's a better cushion, as you see here. And then you just drape it over or cloak it over the distal humerus and use transosseous sutures to hold it down. I think whatever product you use, it's okay. We'll sometimes use, we usually use an Achilles allograft. Recently, we've been experimenting with a product called Graft Jacket. I have no disclosures of either one. I think it's dealer's choice. You then want to put it together, and then we're still primarily using an external fixator. Some people say you don't always need it. You can use an internal type of device. We're still using an external fixator. So this axis pin, if you look at the left picture real carefully, you can see the collateral ligament reconstruction. You can see the axis pin going over the spool between the trochlea and the capitellum. And then you can see the triceps reflected back over on the right side of the screen. Here's your intraoperative fluoroscopy. Again, the axis pin has been removed, but the axis pin is the key because that's what builds the external fixator. And then here's the external fixator in place with the axis pin removed. Here's her passive range of motion, not quite full extension, but full flexion, and her joint is maintaining alignment. We distract a little bit to take the compression off of the Achilles interposition arthroplasty, and then we do our post-operative rehab. Here she is at 2 weeks. Right. She's a super great child. She really fought through it. She did have some post-operative complications with some drainage that we ultimately were able to manage with repeat debridement. We were worried it was infection, but I think it was just a response to the Achilles or the massive amount of surgery. And here she can bring her hand to her mouth. Right. And they have not gone back to Africa. They now live in the United States. And she is followed at the Chicago Shrine. I'm at the Philly Shrine. I'm on the East Coast. Chicago's in the Midwest, right? But here she is at 2 weeks. And then ultimately at 1 year follow-up, which was done in Chicago, her elbow was stable. She was able to eat with her left hand, and her elbow range of motion was 30 to 135. So that's a save from a very distracted, distraught elbow. So let me show you one more example, a little bit different spin on interposition arthroplasty. And this is from the States. So this is Sophia. She had a radial neck non-union. So she's 11. She fell off the couch 4 months ago, and we saw her in 2019, sorry. In 2016, she had a radial neck fracture and ulnohumeral dislocation. Again, treated with open reduction, which is kind of a no-no for radial necks if you can avoid it, but nonetheless, you sometimes have to do what you need to do. Here's her original x-rays. So you can see a posterior dislocation of the elbow. You can see a substantial radial neck fracture. We saw her in 2019, so 3 years later after her injury, elbow contracture of 30 degrees, marked crepitation at the radiocapitell joint. She was not unstable. So she's very different than Aldine in terms of her clinical presentation and in terms of her clinical problem. Here's her imaging studies. So if you look carefully, the radial head has disintegrated. And then the radial neck has performed this kind of spike. And that spike is now driven into the capitellum. So now there's a hole in the capitellum. There's no radial head. And you can see that she is going into valgus because she has no secondary stabilizer. Again, a very difficult problem. MRI shows here, this is a coronal section. So on the left side of the screen, you can see the radius that's remaining has formed this pole, and that pole is driving into her capitellum, and the radiocapitellar joint is destroyed. Now, in this case, the ulnohumeral joint is preserved. So even though she dislocated her elbow, the arthritis is at the radiocapitellar joint. Thoughts? Difficult. So we've been performing interposition arthroplasties in these difficult cases of radiocapitellar joint degenerative changes with interposition only in the radiocapitellar joint, leaving the good ulnohumeral joint alone. So we're going to excise the radial head. We're going to again perform interposition arthroplasty. Again, we used Achilles. So here is the surgery. If you use a Kaplan approach and a Coker approach and work through the windows, you can preserve your lateral collateral ligament. If it gets to the point where you just can't get adequate access, you can obviously take the entire mass down and then repair your ligament. We would prefer to keep the ligament if at all possible. Here's the approach. So this is your lateral approach. The radial head has been resected. This is your Kaplan approach. And what you see is there's just this large groove in the capitellum. Now, what you see here is the combination. The Coker approach is posterior, and the Kaplan approach is anterior, and the ligaments in between. And now we're going to work through these two windows, passing the same transosseous sutures, but we're going to cloak our capitellum with this Achilles rather than the entire joint. Right, so this case we went lateral because all we were addressing was the lateral elements. We weren't addressing the medial elements. Here's your Achilles, and here it is being passed, again, preserving the lateral collateral. So over the capitellum from the Kaplan to the Coker approach, and here it is posterior. It's stuffed pretty tight. You want to overstuff a little bit with this. And then here's the anterior. So now it's stuffed from anterior to posterior, and now we have a big cushion in a radiocapitellar joint. We've resected a radial head. We've gotten rid of that spike. And here's her range of motion on the table. Standard closure, again, Kaplan above, Coker below. Here she is 2 weeks postoperatively. So we have put this big Achilles as a cushion, and you always wonder what's going to happen over time. You would think the cushion would flatten and she'd have a little bit of progressive valgus, which is what's happened over time. But the great news about Sophia, we've hung in here. Here she is 2.5 years later. This is her horse named Clinton. This is her x-rays, which show preservation of the radiocapitellar joint, range of motion. So it's and she has no pain. She does have some valgus, which you'll see, but her range of motion is almost full, and her supination, as pronation has been maintained. So I think for isolated radiocapitellar joint degenerative changes, consideration of some form of interposition arthroplasty with whatever's your favorite interposition material is probably the way to go. And that to us is just a home run. And with that, I will stop. Thank you very much for your time this morning. Jane, back to you. Jane, I think you are on mute. I think you're still. Jane, are you off mute now? Yes.
Yes.
Ken, you want to talk us through this, or you just want to run it? Paco, do you hear volume? I do not hear volume.
No, I don't.
Yeah.
I think we have to read it.
We're not that smart, but we'll try our best. But Paco, you feel that you need to see how Jane does this to really get an idea how to do it clinically, right?
Yes.
It's still a pretty nice video, actually. So Jane, people are going to ask, can they look at this? Where do they look at this video? Is it on your website?
No, not in my website. I can to submit this.
Jane, do you mind if I share your video here
Okay.
in the Zoom?
Yes. Okay.
Yes.
Yes.
I know you share with everybody. I know you share with everybody, but just okay. So it's downloading.
It's okay.
Thank you, Jane.
Paco, maybe you can help her with like technical tips as she goes through this or something. Any idea? Because you've done this.
So I because I have a really bad signal. I don't see very well the video. Sorry.
It's okay. I think what she did there is important because back.
I see it like interrupted. I see it like very interrupted.
Oh.
So she uses the technique proposed by Bike from your friend from Korea.
Yeah.
I think it's the same technique,
Uh-huh.
but she's very precise regarding the positioning of the bone. So Jane sutures the bone and then fix it with a 0.6 K wire. So now she's suturing just the small piece of bone from the lateral segment to the bigger bone from the medial segment. So she's passing now the suture, but she will tie it later. So she's passing the suture now through the bone. And the nail bed in the so she leaves a lot of nail bed in both sides. So then she trim it to make it perfect. Still passing the suture through the bone. And she's really meticulous in the position of the bone. So they have really to be at the same level. So now she's passing the 0.6 K wire.
Yeah.
So fixation of the bone is a K wire and suture.
And that goes inside out, right?
And then after the K wire fixation, she's suturing making the knot of the bone suture fixation.
Oh, I see.
So after the K wire, she finished the bone suture. Okay, this is a 40 PDS.
And Paco, the nail bed is a suture.
She's doing the suture of the nail bed with micro instruments and the microscope 90. So she trims the nail bed perfectly and do this non-running sutures 90.
And then this is the nail fold, right?
Yes, this is the nail fold. So she did first the suture of the nail bed under the nail fold. And now she's suturing the palmar skin. So So
I
she
didn't ex-
uses this is the way to fix the nail plate.
Is that suture go around this K wire or no? Oh, I can't. Oh no, I
Say
see
that
it.
right?
Yes.
I think that the video
Oh,
has been now shared.
I don't see it yet, Paco. Oh, I don't, well, maybe I do. Yes, I do.
No,
I got it.
Oh, I will show another cases. Not the video and
no.
the pictures and this um this case. So the before surgeries. This right hand, the left hand. The left, I did the BC procedure for the left hand, left thumb. Yeah. Sorry. This is the right. This is the right thumb.
Wait, all I see is a bunch of slides.
Yes, there's the left.
A bunch of slides. You see,
And this the follow-up. So
Jane, I'm still seeing thumbnails.
yeah. And the follow-up. The distance is a little smaller than Felix. The different type 2, and the radio polydactyly is very smaller. Is the right thumb, yes. So before this,
Yes.
different. So I was very recommend this BC procedure. So well,
Jane, we only see small pictures. We don't see
Big pictures.
Jane, I have a really bad signal here in the mountain. Do you mind to share yourself the BC video here in the Zoom?
video.
Andres, what did you put
your
in the Zoom?
BC,
Sorry, Scott, what you said?
What is that? What did you put it up? Is this the video of what we just saw?
yes, but yes, the same video. But the
Yes,
problem
I can send it to you.
yes, but at Zoom, because I cannot download it. I cannot upload it because of my connection is weak.
It's caca.
Oh, okay.
Si caca de lava.
Caca signal.
I send the email to you.
No, but I have the video, Jane. I have it, but
Oh, you have
my connection is very bad.
Okay.
So if you can, if you go to participants, not to chat. If you go to chat at Zoom, there you gotta upload it. If you go
I
to
think
chat,
Andres did.
What I said is that the video that we saw some minutes ago in the Zoom, it will be uploaded to the YouTube channel later, like all the well, the talks.
Okay,
But
perfect.
if
Or
she has
let's do it.
another,
Let's do it. You just mail me and I'll send you the video, because
Okay,
I
great.
don't want Jane Shen to lose her time sending the video.
No, I agree. So do we have any other, Paco, any other questions? Oh, wait.
I have
So
one question for you, Scott, about the elbow. How long with the external fixator?
So the question was, how long the external fixator? As long as I can possibly maintain it. So at least 6 to 8 weeks if they can maintain the pin sites. But we let them, once the incisions heal, they shower, they take care of the pins. I don't do anything special for pin care, but I like to leave it on for at least 6 to 8 weeks, even up to 10 weeks. Longer the better. Good question.
And Scott, how important are those wings to reconstruct the ligaments?
I don't think they're that important. It's a good question. So Paco asks, how important are the wings to reconstruct the collateral? I think there's often enough scar that forms that you don't necessarily always need the wings. They just make you feel better.
So because I used this Scott Kozin technique a few months ago in one patient. I asked Scott and he sent me all the stuff. And so the patient is so happy, Scott, so happy.
Yeah.
Because he had zero motion. He had 3 surgeries for a stiff elbow, but I wasn't able to reconstruct the ligaments. And the result is incredible. He has maybe 90 degrees of motion, which is incredible for his situation. And
Yeah.
I couldn't reconstruct the ligaments.
Yep. And remember, once you do this technique, the x-rays never look good. So don't expect the x-rays to look good. The x-rays always look like caca, but if they can bring their hand to the mouth and they can feed their fairly happy patients. But it is a big operation. It requires a lot of dedication on the patient's part to get the elbow moving.
Scott, how important do you think that elbow joint congruency, how important do you think it is in a child? You mean we are obsessed with the perfect reduction, chondral reduction? What do you think about that?
I do think it's important, Puck. Maybe not perfect, but perfect.
Yes, because those lateral condyle non-unions that you do in situ fixation, so you don't restore the congruity, and they do very well with very good motion. That's why I do the question.
No, it's a great question. You're right, they do very well, especially if you get rid of the ulnar nerve irritation and you get them aligned. And you're right, you're not even trying to restore articular congruity. It's a good question. I don't know any study that has followed them long term. We should probably ask Tien to look at his results because it's been 20 years.
We have another question in the chat that says, what would you suggest in case we don't have allograft availability?
So when I first started doing it, Andres, I used autograft. I used the iliotibial band. So I don't think the lack of having a allograft is okay. You can use their own iliotibial band without any problem, right? And I think you just have to understand that when you take the band, you have to put a drain in. You may get a little bit of fascial hernia, but their own iliotibial band works fine.
Thank you. And there is another one. What is the lifespan of elbow interposition arthroplasty? Is it if it is performed again, how successful it is?
I've never done it a second time, and I don't know if it either does one of 2 things. Either it really works, or it just falls apart because you haven't restored stability, like Paco said, and that there is no good salvage. There really isn't. It's Paco. Have you ever had a revised one? I have not.
No, I've just done one case.
Oh, but I don't think Dan or I have ever had to revise one of our interposition arthroplasties. I think probably what happens over time, it may degenerate a little bit. They get a little bit more stiff, but as long as they stay stable and they're painless, It's almost like a Charcot joint. If you think about it, you've taken down the entire joint, every single proprioceptive fiber. So it's probably like a Charcot joint. I bet the X-rays look horrible at 20 years.
Jane, should we stop?
I think so.
Stuff. Because today.
Yeah, go to the swimming pool with your kids. You should. But Jane, thank you for a very good
really
session.
amazing session today.
Yeah,
Thank
it
you,
was
Jane.
really good.
Thank you, Jane. Amazing today, Jane.
All right, everybody enjoy the rest of their Sunday.
Bye-bye. Bye.
Bye.
Thank you, guys.
Thank you, Jane.
Bye-bye. Thank you,
See
Jesco.
you soon.
See you soon. Yeah. Bye-bye.
See you soon.
See you soon or see you by Zoom.
See you Friday, next Friday.
Hey.